Hello guys, welcome to DH exam prep. As you already know that we have studied a series for pharmacists who are preparing for their DH exam. Here I would like to make things clear that I'm not going into the little details. I would focus on the portion and the sections that are being asked in DHA. At the end of this video, I will ask some questions from this lecture and the questions that have been asked in DHA before. So please make sure you watch this video till end and answer those questions to test your knowledge. Before starting, I would request you guys to subscribe my YouTube channel, which is basically created to help you guys in your DHA journey. Without wasting your time, let's start in. The first portion is in pharmacology that I will discuss with you guys is psychiatric, and in psychiatric I'll discuss depression. As we already know that depression means that we have a lower serotonin levels in our body, and what we have to do is we have to stop the reuptake of serotonin, right? But they won't ask this. What they will ask in DHA is, what if a patient is facing depression along with seizure? What you have to do? The drug that you have to do in patient who is depressive with epilepsy, with or without hypertension, you have to give him paroxetine, which belongs to the SSRIs. And we know, and what do you know about SSRIs? Selective serotonin reuptake inhibitors. And what are the selective norepinephrine reuptake inhibitors? Those are venlafaxine and duloxetine, and we know that duloxetine is being used for the neuropathic pain. Alright, so the next thing is, what if a patient is facing depression and seizures, right? What should be avoided in that patient? And the answer is bupropion, right? Because bupropion increases the chances of the seizures, so that should be avoided in those patients. And if a patient is facing depression but he is overweight, what should be done? So the drug of choice for depression patient who is obese is bupropion or venlafaxine. Drug of choice for the epileptic patient who loss of appetite, right, who is facing anorexia, so he should be given mirtazapine. Here we have a short notes about the bupropion, that it increases the chances of seizure, but it's good for obese patient and it's least sedative. So the question that is being asked in the DHA is, which of the following antidepressant is least sedative? So you must know that it's bupropion, right? So here we have a little notes, and they are telling us that antidepressant which act on which area in brain. So we know that that's the postsynaptic portion, and the anxiolytic with least sedative and withdrawal symptoms, that's bupropion. As we already discussed here, that least sedative and anxiolytic is bupropion. What if a patient is obese? So you have to give the patient bupropion or venlafaxine, right? If a patient is thin or facing anorexia or loss of appetite, that should be given mirtazapine. And the cardiac patient who is facing depression, we should be given sertraline or paroxetine, and both of them belongs to SSRIs, and SSRIs are safe in cardiac patients. But if a patient is facing depression along with seizure, what should be given? Escitalopram. And for anxiety, SSRIs are the best option. For insomnia, we have already discussed that mirtazapine and paroxetine are the best option. But for pregnant patient, what can be given is sertraline, and for breastfeeding, sertraline or paroxetine. But make sure paroxetine is contraindicated in pregnancy. Here we have some examples of SSRIs just to recall, and the examples include citalopram, escitalopram, fluoxetine, fluvoxamine, and sertraline, right? Then the next thing is tricyclic antidepressants. We already know there are two major classes of the tricyclic antidepressants. They are secondary or tertiary, and the examples include, for the secondary are protriptyline, nortriptyline, nordazepamine, and for tertiary includes doxepin and amitriptyline. And these are just examples to recall, but the question that is being asked is amitriptyline cause arrhythmia. So you must know that it can cause arrhythmia The next things are monoamine oxidase inhibitors, and when we classify them, we know that they can be non-selective. They can either block either of them, MAO-A or MAO-B, and the examples include phenazine, phenylzopramine, and azacitidine. And we know that they should be avoided to give with tyramine containing food such as cheese, because they can cause a hypertension crisis, right? And the selective MAO-A inhibitors include the meclobemide, and the selective MAO-B inhibitors include acetylene or salicyline, right? And the tablets of salicyline are basically used for the Parkinson disease, but their transdermal patches are being used for the depression, right? When we are talking about drug switching, like if a patient is taking antidepressants, but they have to shift to another drug, like for example, he is facing insomnia and he should be given benzodiazepines. So what is the time period between them? What should be their washout period? So for other antidepressants or such as MAO inhibitors, the washout period can be 2 weeks, except fluoxetine. So that's the main question here. You can say this is the main question, and they can ask like, what if a female is using fluoxetine, but for insomnia doctor has prescribed her benzodiazepine, so what should be the washout period? It should be either 2 weeks, 3 weeks, or 4 weeks, and you have to select 4 weeks, right? Here we have a short notes about bupropion, and we know that that should not be used in seizure or pregnant females, and they can be used in patient with sexual dysfunction developed after using SSRI. So this is the drug of choice here, and bupropion can also be used in the obese patients, because this helps to decrease their weight. All right, the next section is anxiety, and the first line in anxiety are SSRIs. We know the examples include fluoxetine and paroxetine, sertraline. The drug of choice for the anxiety is buspirone, not bupropion, because bupropion is being used in depression, and I hope you know the difference between them. And moving toward the next, tricycling antidepressants are also being used in anxiety, and that's the second line, propranolol, which is the beta blocker, and that's their off-label use, and they are also being used in anxiety. So people who appear in their exams, they use sometimes some of them use propranolol as well to overcome that exam anxiety, and they are taking them. Here we have a short note that bupropion should not be used with MAO inhibitors. Benzodiazepines are also used, but because of their withdrawal symptoms, hypnosis, and because of their side effects, these are the last choice. So they are being avoided in anxiety. Examples of benzodiazepine includes alprazolam, diazepam, diazepam, oxazepam. You already know that. Here we have a short note that bupropion should be used in depression, while buspirone is being used in anxiety. Chlorpromazine is basically antipsychotic, but it has some antiemetic effects for cancer patients. The next section is antipsychotics. Antipsychotics are being used for the psychosis and schizophrenia, right? So there are basically two classifications of them. You can classify them in first generation, also known as typical antipsychotics. Their major side effects are extrapyramidal side effects, and they also worsen the negative symptoms. And the examples include haloperidol and chlorpromazine. We just discussed that here, that it is also used in cancer patient for their antiemetic effects. Chlorpromazine causes pigmentary on retina and cornea, so it has some side effects on the eye as well. The second class include atypical antipsychotics, also known as second generation drugs, and their major side effects include metabolic side effects, and the metabolic problems such as diabetes and obesity and all that. And the major examples include clozapine, aripiprazole, olanzapine, and quetiapine. And we know that clozapine causes agranulocytosis just like propylthiouracil, right? So if we have to monitor absolute neutrophil count and white blood cell counts, just to know that either we are facing agranulocytosis or not. If we are, so obviously we have to stop the drug. Antipsychotics for Parkinson patient include quetiapine or pimavanserin, while for tardive dyskinesia, the FDA approved valbenazine, and medications to cope up with extrapyramidal side effects include benztropine, this is anticholinergic, diphenhydramine, antihistamine, and benzodiazepines. So they may ask in the exam that what should be the drug of choice for a patient who is on antipsychotic drugs and facing extrapyramidal side effects. So he should be given benztropine. Most effective in treating positive symptoms in schizophrenia. We know second generation or atypical antipsychotics are being used in schizophrenia. What are those drugs that worsen the negative symptoms and develop extrapyramidal side effects? And those are first generation, and first generation are also known as typical antipsychotics, right? Psychotic patient take olanzapine with high glucose. So this is the basic question that can be asked in the DHA. But if a patient is psychotic and is taking olanzapine, but when we check their blood glucose level, it's on the higher level, what should be your intervention as a pharmacist? So you must ask the doctor to stop olanzapine because this belongs to the typical antipsychotics, sorry, atypical antipsychotics or second generation drugs, and those atypicals may cause high blood glucose level because of their metabolic side effects. So the alternative option is haloperidol, which belongs to the first generation and have lesser metabolic side effects. But if a patient is using clozapine but he's also a smoker, so if a patient is using clozapine and olanzapine, smoking is basically an inducer, so it increases the metabolism. So when you are giving a drug with an inducer, and inducer will increase the metabolism, and you have to increase the dose in that case. And also in this case, you have to increase the dose of the olanzapine if a patient is a smoker. The next section includes bipolar disorder. We know that the drug of choice in that case is lithium. In acute cases of mania, we can give valproate or lithium plus antipsychotic, and in bipolar disorder, lithium, lamotrigine, also lurasidone, which belongs to the antipsychotics, olanzapine, again antipsychotic, and fluoxetine belongs to the SSRIs. For the maintenance, so this was about acute bipolar or mania disorder. But if we have to maintain those conditions for mania, you can add lithium along with second generation antipsychotics or atypical. And for bipolar disorder, if you want to maintain, you can give lamotrigine. So basically there are basically two drugs that are mainly used, and those includes the lithium and lamotrigine. In pregnant patient, the drug of choice should be the lamotrigine or levetiracetam, and we know that lithium is a mood stabilizer, so this is the drug of choice here. While moving toward the side effects, lithium may cause tremors, gastrointestinal problems, edema, and hypothyroidism. And when we are discussing about the hypothyroidism, you must know that what are the other drugs that may cause hypothyroidism, and that are amiodarone, valproate, carbamazepine, as well as sulfonylurea such as tolbutamide. All right. So what they may cause? What lithium may cause? It decreases the creatinine clearance, increase blood urea nitrogen, hence renal impairment. So you must take a note of, or you must keep on testing these things when you are on lithium therapy. Toxicity may include decreasing the sodium levels, and so you must avoid to give it with ACE inhibitors and diuretics. So when we are talking about the monitoring, you must monitor the blood levels 30 minutes before the dose, and must be drawn after 8 to 12 hour post dose to know what's their level in the blood. And while you are on lithium therapy or your patient is on lithium therapy, you must monitor their renal and thyroid level every 6 to 12 months. So these are basically the notes that you must know the things about lithium. Counseling notes for lithium: that if a patient is using lithium, he should be hydrated, limit sun exposure, and take it with food to decrease nausea. He should be cautious with driving and other heavy activities. If a patient is using lithium and because of the lithium toxicity he has to face convulsions, that can be treated with phenobarbital, propofol, and benzodiazepines. While the antidote for the lithium toxicity includes sodium polystyrene sulfonate and sodium bicarbonate. At the end of this lecture, here are some questions as promised, and I would appreciate if you guys answer these questions in the comment section. So the question number one is, which of the following agents can exert an antipsychotic effect which appears to be due to a dopamine receptor blockade in the central nervous system? So the option A is fluoxetine, option B is bupropion, option C is bromocriptine, and option D is chlorpromazine. Question number 2 is, a 22 years old male present to the primary care physician with complaints of uncomfortable sensation in his legs during the day, and he must constantly move them. History reveals that he has schizophrenia and he is treated with antipsychotics over the last 3 months. Which of the following antipsychotic agent is this patient most likely takes? Option A is clozapine, option B is haloperidol, option C is olanzapine, and option D is risperidone. Question number 3 is, a 75 years old patient has a seizure, a history of arrhythmia, and is diagnosed with depression. What's the best management? Option A is bupropion, option B is paroxetine, option C is mipramine, and the option D is fluoxetine. That's it for today, guys. Please like this video and share it with your friends. If you didn't, please subscribe my channel as well. Till the next time, have a good day.